Good afternoon, good evening, everybody, depending on where you are in the world. Thank you for joining us to this event. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. Before we begin, a quick word of thanks to everybody who makes today happen and all our public health conversations. In particular, thank you to Meredith Brown and Alicia Noel for arranging today's event. The past 2 years have seen perhaps the most public engagement with conversations of consequence for public health in generations. Here at the school, we have engaged with these discussions through a series of public health conversations. This is one of them. We are very glad you are here to join us today for a conversation that I think has been very much front and center in our collective consciousness in the past 18 months, vaccination. We are living in a moment where it feels like we are living vaccines acutely. We often forget in a moment like this that there's actually a long history of challenges with vaccination. For example, in Victorian England, tens of thousands of people took to the street to protest against mandatory smallpox vaccination, with a number of people ending up being jailed. In the US, George Washington required his troops to receive smallpox inoculation. And the US, of course, saw enormous social movements around the polio vaccines and now conversations around COVID-19 vaccines. Historically, our engagement with vaccines has been characterized by both an embrace of what they do, often with jubilation, for example, at the polio vaccine, and by skepticism and downright hostility towards them, some of the feelings that we're also seeing percolate right now. Since the emergence of COVID-19 vaccines, the end of the pandemic has seemed within reach. But hope for a quick conclusion to this crisis has been tempered by lags in vaccine uptake, driven in no small part by vaccine hesitancy, as well as by access in many parts of different countries and many parts of the world. Further mitigation of COVID requires us to better understand this hesitancy and understand the reasons why we're not able to vaccinate as many people as we think we could be able to vaccinate in a short period of time. For many of us, this means opening our minds to a radically different perspective, to see how what we may view as self-evident good can be regarded by so many with suspicion. I think to help us do that, today we are joined by the world's leading expert in thinking about this, Dr. Heidi Larson. Dr. Larson is a friend and colleague, and we're very grateful to have had her serve, most recently as a commissioner on a recent 3D commission, a report of which was released last week. Relevant to this conversation, Dr. Larson has released a new book a few months ago called Stuck: How Vaccine Rumors Start and Why They Don't Go Away. It's a book that examines the origins of vaccine hesitancy and efforts to address the anxiety and reluctance surrounding vaccines. For anybody who has not read it, I highly recommend it. It's a terrific read. I'm really delighted to be welcoming Dr. Larson today, and I look forward to learning from her. Heidi, over to you.
Thanks, Sandro, and I'm really thrilled to be here virtually. And I'll kick off with my slides. Okay, well, I'm going to talk a bit about understanding vaccine confidence and vaccine hesitancy, part of different parts of the spectrum, and with one thing that I want you to stay with you during this is one thing I've learned in my kind of nearly 2 decades of thinking and working on this issue is never assume what's in the minds and emotions of people, and particularly recently, never forget that they can change. This is a highly volatile, but also there's been a long trajectory of, I would say, confidence declining. It didn't just happen with COVID. I think we had a number of different underlying factors that have given what we're seeing around COVID in terms of the whole mix of emotions and perceptions and enthusiasm, and yet a refusal around vaccines is really just an eruption of decades long of different kinds of sentiments underlying erosion of trust. And it's happened at many levels, but hopefully this COVID experience will put us we'll recover from this stronger. Already in the 80s, there was science looking at the decline of deference, the decline of not looking just to authority. Even Margaret Chen, the WHO Director General in 2010, that's 11 years ago, already was saying to her executive board the days when health officials could issue advice based on the very best medical and scientific data and expect populations to comply may be fading. Well, they already were fading, and they've come to a whole new level. But I respect her for having had the humbleness, actually, to bring attention to this. Recently, in Science, with my colleague David Broniatowski, we wrote an article about the volatility of vaccine confidence, and with that, vaccine hesitancy. And just to say, sometimes these terms are used interchangeably. They're not. Vaccine confidence, which the research group I founded in 2010, I called it the Vaccine Confidence Project a bit, and then developed a Vaccine Confidence Index, a bit inspired by the Consumer Confidence Index in the sense of public sentiment about confidence in willingness to spend, and in this case, willingness to be vaccinated, but how they were anticipating acceptance of a vaccine. But in that spectrum of 0% confidence to 100% confidence, somewhere in the middle there is hesitancy, indecision, but they don't equal each other. And I didn't choose hesitancy as a frame because it's always hesitant, and confidence, you can be very positive in your confidence. But these levels we see in our index are changing constantly. People's confidence goes up and down, and vaccines are very much a kind of canary in the mine of underlying confidence in the system. We monitor vaccine confidence globally, regularly, and as you can imagine, we've been focusing a lot on COVID and COVID vaccine confidence. This is from the end of 2010. We did a 32 country analysis. And why I'm picking this one is because we also look at a lot of the socio-demographic and other background factors. And we saw the one factor that was overwhelmingly the most correlated with positive intention for vaccines was when people had trust in the government handling of the COVID response. This was a stronger lever than anything else: age, education, employment, income, health level, other stress factors. That was the thing, that was the lever for their willingness to take a vaccine. Do we trust the government? Are they handling the pandemic well? Already in 2013, the World Economic Forum that runs annual risk reports, their read on the environment for multiple levels of where are the fault lines, where are the risks ahead. In 2013, they called out as the top 3 domains of risk: digital wildfires in a hyper-connected world. This is almost 10 years old. Economic and environmental resilience, and the dangers of hubris on human health. Now, this is not unlike what Margaret Chen had said in 2010, hubris, the scientific and health community thinking that they know the sense of authority. But I would add, and I'm seeing more and more in our research, that there's also a hubris in the public about what they think is best. So there's this tension between the hubris of the experts and then the anti-experts. We know better. Whether it's natural food, whether it's different approaches to health, there's also a different kind of hubris. So I think at many levels, we need to be humble. And then you throw in the digital wildfires in a hyper-connected world, which now we look at in my group, social media wildfires, digital wildfires, and something I also talk about in the book. In 2013, WHO, the SAGE group, the Strategic Advisory Group of Experts on Immunization, recognized that this issue was becoming a problem. I had been leading UNICEF's strategy and communication around the introduction of new vaccines and launching Gavi in 2000 to 2005, and was trying to bring attention to that already we were having issues, but WHO wasn't ready to hear that yet. But by 2013, they had enough countries coming to them saying, help, we have a problem with our public's confidence. And so they convened a working group on vaccine hesitancy, and I was one of the 11 members. And our task was to map the state of vaccine hesitancy, characterize it, and then look at what can work and give some recommendations. So the first thing we did was a review of the literature and identified 3 key areas of influence: contextual influences, politics, religion, historical, individual and social group, your peer influences and things happening around you in your society, community, and then vaccine and vaccine-specific issues like the safety, administration, different things specific to the vaccine. Already, this was an evolution because it recognized that it wasn't just about the vaccine. And that's where I think there was a real turning point in the understanding or the acknowledgement of this issue. This is not just about the vaccine. This is about the system. This is about religion. This is about politics. This is about a lot of things that determine people's sentiments around vaccination. A lot of people say that, well, if we improve this health system, that's going to help. That's going to be a key factor. But we couldn't find any research anywhere that really showed that specific to vaccines. So we did a big global study in India, Pakistan, Nigeria, and the UK, looking at a measure of hesitancy against confidence in the health system. And what we saw, now it's not my favorite graph in terms of explaining itself, but those blue bars are levels of hesitancy. So where you see, the blue bars are the level of hesitancy, and what's written in them is the level of confidence in immunization services. So the lowest level of hesitancy, the lowest blue bars, consistently have a lot of confidence in immunization services. So where it says none at all confidence, no confidence in the immunization service are pretty typically the highest level of hesitancy. So we finally felt like, okay, we've got some numbers on this. But in all this mapping, in all of these different ways we were trying to get our handle on and map and characterize what is hesitancy, what's driving it, there was one thing I feel like looking back how it's evolved over the last 10, 15 years, or at least in terms of the scientific research on it. One of the big areas we really haven't taken into account and is the dimension of emotion and belief, but particularly emotions. And in March 2020, together with the Lancet, we launched the Vaccine Confidence Project at the London School with Lancet, the Emotional Determinants of Health Commission, which frankly was parked because COVID hit, and we're coming back to it and reshaping it. And actually, that's in a way, a good thing. One, we've learned a lot about emotions in the past year, but also we will have the absolute benefit of building on the incredible work that Dean Galileo did in the 3D, the data determinants, in the last that you had mentioned earlier, that we worked so hard, and it'll be a perfect foundation to move on into the emotional investigation. So we saw also the extent of emotions. This is not just a luxury topic. This emotions and fear led to polio workers being killed. In Ebola, we had health teams killed because of people's fear of the health workers. They didn't trust them, and it really created violence. We saw this in polio also, and these different and Ebola vaccines when we started to bring them in. So when we think about things like misinformation, I see a disproportionate amount of misinformation, attention to misinformation, but really I see misinformation as a symptom, not the cause. People believe pieces of misinformation because they don't trust, because they have fear, because they have anxiety, and somebody's coming along with an explanation that may not be credible, but somehow it answers these anxieties. So I think we need to take a different look at it, and not everything out there that's wrong is misinformation. It may be doubts, it may be skepticism, it may be other accidental misinformation. This is another thing, though, we didn't have data on. So with my group, we did a randomized control trial with 8,000 people, 4,000 in the US, 4,000 in the UK. We interviewed everybody about their COVID experience and asked, would you be willing to take a COVID vaccine? In the UK, 54% said definitely. And in the US, it was 41% definitely. And then we showed 1,000 in each country, positive, straightforward, credible information about the COVID vaccine, and 3,000 in each side, the most frequently circulating pieces of misinformation. And then we went back to all of them, interviewed everybody again, more about the COVID experience, but again put in the question about willingness to take a COVID vaccine. In both countries, there was over a 6% drop in people's intention and willingness to take a vaccine, the COVID vaccine. So we finally had some numbers. It does have impact. Whether or not, if we went back in 2-3 months and asked the same question, we don't have that data, but it did give us a metric. And one of the things I learned in this field in trying to get some characterization of this field is that without getting some metric around it, it's much harder to do something about it. This is not just about the facts. This is about belief and trust. It's important. It does have an impact. We have measurements on that now. But we still have the challenge ahead of these deeper beliefs that no fact is going to help. COVID is a scam. This is not true, but there's a lot of deep beliefs in it. COVID is a lie. It's a hoax. And these are not just conspiracies from the heart of Africa or some other country that doesn't have the information. These are in some of the most educated populations in the world. This is not about getting the information right alone. We also have the issue of leadership, presidents in different countries. From the US to a number of countries in the world, promoting alternative healing and organic drinks in some countries you've got the shopping list of what we've been hearing about. But this is another thing that we need different ways to address these other beliefs and emotions that will not be fixed by better information. So we need to work into our communication ways that we can be relatable to what people's concerns are. We need to be there where they are. As one woman said, I'll believe someone who looks and talks like me, who feels what I feel. So we need to relate to them, not using emotions in a fear tactic. This I saw in down the road from you in Rhode Island in 2005. It was around avian flu. This is emotive, but it's not what we're going to need. But this is a different kind of emotion. This was in Bolivia. And I love this because it is, they use the whole framing for their vaccine campaign, COVID vaccine, doses of hope. So I think we can leverage, there's a lot of attention in the literature on panic, on anger, on fear in pandemics or in certain disease outbreaks. We're not leveraging enough of positive emotions, empathy, hope, dignity, and we have to look at this whole spectrum. So that's one of the things we'll be looking at in the emotional determinants of health, how when people get a diagnosis of different kinds of diseases and have to make clinical decisions about their treatments or about vaccines or about other health interventions, how can we understand and make our exchange with them relatable and something that mixes and understands the emotions as well as the facts. And just a last couple of things, just in terms of what do we do about it, aside from getting more empathy and relatable to where people are at. We did a global, together with the World Economic Forum and one of their partner organizations, NetBase Quid in California. They used their access to, they normally do reputational and client research for companies, but they did pro bono work with us to listen to all around the world, all their various streams of monitoring social media, any of the conversations on vaccines, and it was all about COVID vaccines, hugely diverse. But the one thing, the important note to think about here is the thing that resonated most, the thing that triggered and engendered positive conversations was the word protect. Protect and protection. Protecting myself, protecting others, particularly when it involved protecting others, that could change a conversation to be one that was more open and led to positive. Any conversation that suggested or said there was a moral obligation totally provoked a negative response, shut down conversations. So these are the kind of clues we need to understand for moving forward. Oops. And this is just the last slide, the book that Sandra mentioned, and just so you see the table of contents. It's about dignity, it's about volatility of opinion, it's about emotions, belief, and pandemics and publics. And it came out just before COVID was announced, funnily enough, but it's pretty relevant. Thanks so much. Sorry to talk a bit. I hope I stayed within my time.
That was perfect, Heidi. Thank you. We have a lot of questions as I expected, but I'm going to start with the sort of a chair's prerogatives to start with 2 questions of my own, and then we'll go to the questioners. So Heidi, maybe we can start with chapter 2 of your book, which is something you and I have actually exchanged notes about. So chapter 2 is about dignity and distrust. And can you, I've written a little bit about dignity and you've written quite a bit more about it. Can you just talk a little bit about dignity and the place that dignity has and how it factors into the issue of trust and distrust in vaccines?
Sure. I think one of the, I had been on BBC on a morning talk show, and as I was leaving the studio, I got a call. I think sometimes examples tell the story best. I got an email from a woman who said, my friend and I just heard the program. We just want to thank you for not blaming parents for the problems. And then they said, one of them asked if she could come in and meet me and talk to me. And because I'm always talking about being open and listening to conversations, it's kind of hard to say, no, I don't have time. So I made the point of meeting. And one of the things that she brought was a dossier of newspaper clippings, of testimonies from peers and colleagues about how parents who had some questions about vaccines. They were not anti-vaccine. They had genuine questions. And the way they were judged, the language they were used, the humiliation they felt because they asked some questions about vaccines. And I think one of the things they wanted was a little bit of respect, a little bit of sense of dignity. And I think that was one group of mothers. But there were, in other situations, in other communities, it's not even specific about the vaccine. It's dignity of how people feel treated in the clinic, particularly we see among some of the minority groups in some settings. They don't want to go back there. They felt like they weren't respected. They weren't given any dignity. And it's really important. It's another dimension that is not about the information. It's about how people feel treated.
Thank you. Let me ask you one more question now from myself, and this is from I'm reading from your book. You actually note in the book that some of your views on the subject have, quote, not always been welcomed. That they, quote, question some of the modus operandi of the public health community. So I sort of enjoyed that. I was wondering if you can comment on that. I was wondering if you can comment about the difficult truths that you think the public health community needs to hear that perhaps we have not faced.
Well, I think you see a lot of finger wagging at the public for all these problems with, vaccine misinformation, vaccine hesitancy. And I think that, I've been trying to say without judging anyone that, well, maybe people have a point, or maybe we should at least listen to them. You may not agree with them, but you don't start from saying you're wrong. You have to start from saying, well, why are you feeling that way? And I think that I'm not sure how to say it better, but I think that was not something that was too easy for some health professionals to. They're not used to. I mean, it used to be everyone trusted the local doctor like as much as the local whoever professor. I mean, it was just you trusted. It was full trust, and that's just not the way publics are in general anymore. So I think that's not always been easy for health professionals to feel like their authority was questioned.
Can you comment for a second about, I just want to take off from what you just said, and then I'll go to the Q&A on belief. I made a note when I was reading your book about, you write about the power of belief, and sort of that oftentimes approaches to vaccine feel less like opinions and more like faith. And recognizing that, how does one engage with faith? How does one engage with beliefs?
Well, it's interesting. In our vaccine confidence index, we, after doing lots and lots of surveys and questions and interviews with people, we came down to 4 things. Confidence in the importance of vaccine. Do I need it? Because if people don't feel like it's important, you don't have to bother with the other questions. Is it safe? Are you confident that it's safe? Are you confident that it works, that it's effective? And is it compatible with your religious or other beliefs? So we've been running this survey and this confidence index for a while. And in one situation, I learned a lot about this particular one in the Philippines when there was the new dengue vaccine introduced, Dengvaxia, and 850,000 children had been vaccinated. It was a hoped for, they had horrible dengue epidemics, mortality. But a year after this new vaccine had been introduced, as some of you may know well, there was a risk reported by the producer, the manufacturer, that we need to change the guidance because it looks like if you had no previous exposure to dengue, not even getting sick from it, but if you lived outside of an endemic area, that there was a risk that after vaccination you could get more serious dengue. It was a small risk, but it was a risk. at that point, there was a new government and there was political uproar, and it could be a whole lecture on what happened, but it became hugely politicized about the previous government and how could they have done such a thing. And but in the meanwhile, we had done a background. We had been monitoring vaccine confidence. We had the data from the Philippines from before the dengue crisis, the vaccine crisis, and we reran the survey just after. And we saw a significant drop in the confidence index. And by the way, we used that index as they started to work to rebuild trust, to measure their incremental, and they found that very motivating to see that what they were trying to do was rebuilding trust. But the other thing that dropped dramatically from before and after was compatibility with religious belief. And I talked to a number of people and I said, help me understand why your compatibility with, your religious belief and the vaccine changed. They said, it's about faith. In our religion, we have when we trust and put our faith in something, we put our faith in it. And this incident broke our faith, and it's not compatible with what we believe in and what we've learned faith to be in our religion. It was really interesting. And actually, when you think about it, it's all about interpretation anyway, because any of the major religious texts were all written before vaccines even existed. So as we know, it's about interpretation.
That's really interesting. Let me go to some of the questions we're pouring in. We'll take one from Mary Woolley, who commented on this recent write-up about Portugal, which apparently had used a military approach to vaccination with a high success in vaccination. They used war imagery and language. So it seems in stark contrast with Bolivia, rather than going with hope, they went with fear. And she's wondering, and I'm wondering too, about your take on that.
Well, we're watching Portugal closely because it's really, in the last few years, has had quite high vaccine confidence. So it'll be interesting to see what the knock-on effect, because they already had higher confidence in vaccines before COVID. And some cultures respond differently. But one of the things we've seen with fear tactics, they may work initially, but people, it's like, this will kill on a cigarette box. Maybe a couple times it makes you think twice, but then in the beginning of HIV and the AIDS epidemic, the skull and crossbones, the fear factor was scary in the beginning, but then you can't keep using that. So I think maybe in certain moments it can have a trigger effect, but we're watching. It's been an interesting, I don't know.
Well,
thank you, though. I appreciate that, because I was just looking at some Portugal data today and was
I think it's an interesting example in data. So let's now go from the national to the individual level. There's a question from Wayne Stelk, who takes the psychology approach and who says that the literature on personality, there's quite a bit of literature on being more fearful versus less fearful personalities. And it sort of correlates with the big 5-factor model about difference, conscientiousness versus openness. And I suppose the question is, what are your reflections on sort of personality types, psychological personality types intersecting with some of these questions we're talking about right now?
Well, that's a big one. Well, I think there are some people who are more psychologically tend to be more anxious, tend to be more hesitant. But I think that's one of the reasons it's important to understand where people are coming from before you start either judging or I think it absolutely does affect people's how they make their decisions, let's say. But everybody's a little bit different. And I think that's the kind of thing that it will never hurt, no matter what the person's psychological state is, to hear them out, to listen first. And I think it's particularly true in the context of like pandemic and COVID. But in a lot of the outbreaks I've been working closely with in the last years, from Ebola to Zika to SARS and avian flu, those are particularly heightened, even more kind of stable, I would say, psychological states can be anxious. So I guess I would just say I would try to get a read on how people are feeling before you start giving them a health lesson.
So here's a question that puts you a bit on the spot, so I'm just labeling it as such. So the person is asking about the CDC in this country, but I think we can generalize it to sort of health officials more broadly. If you had the authority to sort of to design how we're communicating about COVID vaccines right now, how would you do that? Given what you know, what kind of messaging do you think would be most effective right now, given a goal to get as many people vaccinated as possible?
I actually think the things that have worked the best, and maybe it's partly just the state system, but I see it also even in the UK and in some of in some of the African countries I've been working in, that actually Asia too, pretty much everywhere, that the more local, the better. And I think that on the one hand, there's certain things that you need consistency on across all locations, from a policy level, from the actual technical details and what's needed at that level. But how that plays out, how you deliver them, and how you message really needs to be local. It's where we've seen the best traction, the best responsiveness in terms of uptake.
Thank you. I'm going to combine a couple of questions, one from Marla Clayman, one from Leonard Glantz. But the question is, can you talk about why sometimes sort of same people hold seemingly contradictory perspectives on different vaccines or vaccines and treatment? So for example, people who are perfectly fine with the flu vaccine and who are opposed to the COVID vaccine, or conversely, people who are opposed to the COVID vaccine but have no problem with monoclonal antibodies to treat COVID.
Yeah, it's a really important question, and we've seen it. I mean, we do routine vaccine confidence monitoring in the EU since 2015, and we added, because our core confidence index is about your confidence in vaccines, in the importance, safety, effectiveness, and compatibility for vaccines in general. But then we've added more and more individual vaccines, MMR, HPV, flu, and this year we'll add COVID. And that choice was particularly to get, lifespan, kind of childhood, adolescent, and adult. And the maps of confidence for those vaccines are totally different. France, when it comes to flu vaccine, it's really, it's almost toxic. It was a really bad experience around H1N1 or resistance, but MMR, not so bad. Which was fascinating, being right across the channel from, the fountain of skepticism about the MMR vaccine in the UK. It's very different. And then in another country, flu is fine. It's the MMR vaccine, or it's HPV is another one that, and I think it speaks to how local these things are, but it's also about politics. You see that in the US acutely, but also when people have political histories or distrust, and it doesn't even have to be about the vaccine. In France, there was the scandal where The HIV tainted blood supply was when the government learned about it, didn't let the public know. When they eventually knew, they said it was, why didn't you tell us right away? And frankly, just before MMR in the UK was the, as they called it, the mad cow disease. And the public had a lot of distrust because they felt like they weren't told the truth for a while. So when the MMR scandal came along and, the government said, the research by Andrew Wakefield, it's we're debunking it, it's not correct. They said, well, wait a minute, you told us then about the mad cow syndrome, and that was a problem. So, those are local political histories. And also, different countries have different issues with different minority groups and how they've kind of experienced that. So some of it has to do with that, but it also depends on, the age, the experience, and it does differ with vaccines. And as you saw with the data I was showing around the COVID vaccine, how the government was handling the pandemic. Now, that wouldn't have been a lever necessarily for an MMR vaccine in the same way.
I think the message that the lesson that a lot of this is local is really important. I think it's particularly important, obviously in all countries, but in big countries like the US or India, where you often look at something like COVID and we look at overall epidemic curve. And of course, there are many different phases of the epidemic in different parts of the country and different approaches to deal with this. I think it's a really important message. Let me build on the politics point you made and take a question from Stephanie Bean, who asked the question about, can you comment about the role political disruption plays and how people see their willingness to take up vaccines? And Stephanie is tying it into the notion of sort of emotional contagion and misinformation that often accompanies political disruption.
Well, there's disruption and then there's overt violence. I mean, you saw in the first, when I showed the 32 country survey on vaccine confidence, Lebanon has consistently shown in the last year the strongest level of do not agree with any vaccine from the government. So, and I've seen this going back to my UNICEF years 20 years ago, we saw in the State of Vaccine in State of Vaccine Confidence, or the State of the World's Children report, that the worst vaccine rates were always in situations of conflict. And that wasn't just because of access. It was, a good part of it was related to distrust and anxiety in government. So they didn't want to take something from a government that they didn't trust.
Interesting. Actually, I wasn't aware of those data. That's really interesting. There's a question from Heather Keith Lucas. Have you seen correlations between reduced confidence in vaccine and reduced confidence in other type of preventive care, things like cancer screening, et cetera?
Yes, and it's one of the reasons we've recently launched what we're calling the Confidence Project, which is going to be our kind of umbrella research area, because we've had so many other groups come to us from our mental health group coming and asking if we can help them understand why people don't want to take their psych drugs. Even a polypill statin program in India said, people don't want to keep taking these with HIV interventions and other kinds of, so there's some underlying factors. I think what's different with vaccines and why it hits so many nerves is that it's government driven, industry touches everyone on the planet, everybody in the world is being counted, and every country's number of people vaccinated go to WHO every year. So anyone who has anxieties about being counted has an issue with their government, has an issue with big business. It plays out. And also you feel there's less personal feeling of choice with individual treatments where you feel like you can have a discussion and you can, where there's a little more individualness about it. It's very different than these kind of mass campaigns that that touch people in different ways, as we can see in some of the protests in the streets, that they've been not just about vaccine, it's about masking, it's about distancing, it's about intervention. It's the intervention part that is breeding some of the reactions. It's a long answer to a short, could have been a yes answer, but.
I think what emerges from all these answers is that there is no simple sort of yes to any of them, and that they actually are either require nuance and context. Let me build on that nuance and context and ask a question from Rufus George, who asks the question, how might one imagine messaging being different if it's coming, say, from public health officials versus politicians?
Say that again.
So given what you know, given what we know, how should public health officials, if they're both communicating, public health officials and politicians, they're both communicating, both towards the same end of increasing confidence in vaccine, but how should the message be different coming from these two different sources?
Well, I don't think politicians should try to be health professionals any more than health professionals should try to be politicians. And unfortunately, in some situations, political leaders have, come across as being health, and it politicizes health. And it's been a bit difficult in COVID because you do need political leadership on these. So those lines have been a bit crossed. But on the other hand, there needs to be engagement, because one of the issues in some countries that we've been working with, governments have not engaged with or listened to, consulted with health professionals. Some of these vaccination campaigns that are happening in all kinds of situations, in sports stadiums, in churches and other places. And some physicians and people who vaccinate feel like they were totally left out of this picture, people who would normally be doing vaccination. And I know in H1N1 in France, the physicians felt like they were not consulted, they weren't engaged. So there needs to be some engagement because you want mutual support, but there also, you're walking a line if you politicize more than it's already politicized health messages. But I do think there needs to be good communication between the two, because that can make things even more problematic. Yeah.
I think a hard question from Sloka Iyengar in particular. So given what we know about misinformation, that much of it's been propagated through the media, many kinds of media, but in particular social media, what are your thoughts about regulation of media and how these messages are communicated? And I would expand on that to say during acute pandemics versus in sort of when we're not in an acute crisis.
Well, I think there's the regulation issue has been particularly targeting the social media companies. But I think that what is being demanded demanded of some of these companies is not understanding the fuzziness of it all. It's not all straightforward misinformation, and it's particularly difficult in a time where the information is changing almost daily. I mean, even for the scientists, we're learning. This has been a whole public education class on viruses and how they evolve and how vaccines are made. Every day, we're learning more and more things. It's stabilized a bit, but in the beginning, so to say something was misinformation, we could have shut down some really important clues or cues. So I think there are some parameters that some of these companies, and I'm in a lot of discussions with them because they want to do it right, but right now, it's like if something clearly would cause overt harm, drinking a quart of chlorine will kill you. don't use that for COVID. That should absolutely be taken down. And what they're doing is removing things that are explicitly harmful, potentially fatal. But the biggest problem right now, which is the bigger C of things, is people seeding doubt, dissent, questioning. Questioning is a healthy thing in democracies. But where there is a lot of ambiguity, and it's a hard place. And so I think we have to be really careful with regulating, because we can also push a lot of these sentiments underground, and that's not helpful either, because then we can't engage with it. We can't, and it's one of the things where our research group is looking at is how things are moving from public spaces to more private circles, and then even more underground, and that's not healthy either. So, well, it's my biggest area of interest and concern right now is what's the best way forward, because we've got some challenges, serious challenges on our hands, and a huge opportunity to, as our website now, Data for Humanity. I mean, just how do we harness this remarkable technological innovation in ways that I think my big, if I could do one thing myself and one button to push, I would slow down the algorithms at the back end of these companies, and just slow it down and give us time to understand what's the best way forward.
Thank you for a really nuanced, interesting answer. We could talk about algorithms for a long time, another time. Let me take a question from somebody who clearly is a fan of your book, from Pragya Kurana. Pragya says that they are mildly obsessed with your book, so that's kind of nice. But in the book, you mention the idea from psychology of omission bias, where choosing not to take action, such as getting vaccination, feels like a lesser risk with less culpability than taking action. So can you speak a bit more about that, and how we should keep that in mind when in public health we try to communicate how the benefits of vaccines outweigh the risks?
Sure. I mean, it is a phenomena, psychological phenomena, that mothers, for instance, even though they have the benefits of the vaccine, they're being told the benefits of the vaccine, and they're focused on the potential risk of the vaccine. For them, the action of deciding give the vaccine provokes a sense of guilt, much more than not doing it. So if something happens to the child and they get a natural illness, somehow that feels less bad, even though it could kill a child. And it's something we need to think about. And because right now, if something happens, they're more focused on the regret they may feel for having made that decision. But one way or the other, they're making a decision. And somehow, I mean, I wrote a whole piece on this about Japan. It's 8 years, this past June, going into a 9th year of the government deciding to not proactively recommend the HPV vaccine because of a small group of people who have had very aggressive anti-HPV vaccine campaigns because of some reactions that a group of girls had, which are very real. They were not deemed to be caused by the vaccine, but they were very real symptoms and should absolutely be acknowledged and addressed. But for the government to not recommend for 8 years and not showing any sense of, I said to some people in the Ministry of Health, what about the regret? Who will have the regret when there was an estimate, a modeling exercise, 25,000 girls could get cervical cancer, and with 5,000 dying because of this 8-year time? Who will have the regret for that? And we need to help frame the relative, but in human terms, because numbers aren't going to do it. Numbers about relative risk just go right by. Put a face on it, put many faces on it.
Well, let me ask you a last question. You've been in this interesting position of having written this terrific book, comes out right before COVID. Then COVID happens, where a lot of these things are immensely relevant. So it's hard for me to think of any other human on the planet who's thought about these issues as deeply as you have over the past couple of years. So with that backdrop, are you hopeful? Are you pessimistic? Are you hopeful that we'll be able to break through to actually move truths forward? Where are you at? Where's your mindset at?
I don't think I would have stuck with this if I hope has kept me going. And I do have hope, and I hope that sometimes they say you've got to get it. It has to get really bad before it gets better. And I think we've reached a point now, and I think that there's a lot more awareness about the issues. And I think it was Freud who said, until you acknowledge you have a problem, you can't start dealing with it. And I'll tell you, when I started to first raise this as the concerns around waning vaccine confidence and growing questioning 20 years ago, literally in 2000 to 2005, I was really trying to, without scare tactics, but just say, we need to change how we're working. We need to start building confidence. We're losing people's trust, and nobody wanted to hear about it. And for me, the day the WHO in 2011 convened what was then eventually became in 2013 the Hesitancy working group, that acknowledgement of it. And in 2019, Dr. Tedros declared vaccine hesitancy as one of the 10 biggest global health threats in the world. And he was right. But it took, so I think to me, I'm sorry that sounds like a hopeful thing, but it means that the health community is saying, Houston, we got a problem. We do need to do things differently. That's already, for me, progress. And I think we're raising a generation of young people who are much more savvy, much more conscious of the risks of social media than the first generation who, it was for everyone, it was a new toy, but now we're seeing the limit. So I think we're in a new place, and I hope that COVID has woken us up to a lot of things, and I can only hope.
Well, that seems like a perfect place to end. What a terrific presentation and conversation. Thank you for having written the book. Thank you for pushing this topic forward for the past 20 years, and thank you for teaching us all. I've really enjoyed talking, and I've enjoyed learning from you. Thank you for being a part of it, and thank you to all our audience and all the excellent